Hi, everybody. Thanks a lot for being there. Thank you for CartoNG and the GeoNG just for the invitation also. So I'm Raphaël Brechard, e-health advisor for MSF working in London. And so we wanted just to have this workshop, so it's not only, it's a collaboration between different organizations. The idea is really just to work on health catchment areas. So we will see quickly as an introduction, so what are the health catchment areas and what is the main objective that we have with this group around health catchment areas. And so for this workshop, we wanted first to have something a bit more collaborative and participative. And as it's a work on progress, I think the idea is also just to have a discussion in the end with different people around health catchment areas and how can we improve them. So we will start with a small video just for the definition of the health catchment area. So I'm not so sure. I hope it will work fine. Let's test it.
Health catchment areas are regions served by a particular healthcare facility or health plan. Ministries of health and medical organizations require spatial data of health catchment areas to carry out health surveillance. Regardless of method, geolocations of health facilities and villages within each catchment area are essential to create the catchment areas and improve healthcare provision. Improving our knowledge requires true collaboration, from civil societies to field actors. Through a wide array of tools and shared investment, we can work towards faster and more effective responses to outbreaks in future.
So I hope it worked fine for everybody. It seems I don't hear anything, so I guess it
yes.
worked. So where are we coming from and where are we going to? So the initial question that we had with the health catchment areas is that today in a lot of countries where different medical organizations and other international humanitarian organizations work, we have issues with health boundaries and we have different kind of health boundaries, and one of them is the health catchment area. It's really everything which is linked to a specific health facility or health structure. And there was this article in the Atlantic, and I think we had many different workshops recently where we tried just to understand all the different challenges that we had regarding the data in the field and data and geospatial data. And one of the just common challenge that we found was the quality of the data that we had, and for MSF and other medical organizations, the thing was how to get the most reliable data of health catchment areas and how to get them all centralized. So there is this article in the Atlantic which says that most maps of the new Ebola outbreak are wrong. So it was related to I think the second Ebola outbreak in Congo. And so one of the results of not having health catchment areas was just to have really different maps used by different people. So and all the data were not all centralized. And so there is a question first of having the right data, but there is also the question of having the right metadata with those data and the right information about the user, and can we trust the different users of those geospatial data sets, and where and how to find them, what would be the most reliable way to get those health catchment areas. So our main objective is to create a system that enables each country to manage its health boundaries data in collaboration with WHO and stakeholders in the health cluster. So the thing that we know is that the health catchment area are really dynamic, and perhaps we will see later how it can evolve, and it's not something which is static, but definitely it can evolve in all the different countries depending on many different parameters. We know also that we need inputs from local actors. So today we are a group of different organizations, but yes, we know that definitely we need to have also involve a part of the local communities and local actors. And we have a lot of different challenges regarding the reality of our data and what is exactly how are defined the health catchment areas. So we will see just after several examples of lessons learned of people already who worked on those health catchment areas and all the different challenges regarding what is an official health catchment area and what is not, and how to manage those different versions of health catchment areas. Globally, part of the group is, I think the list is not exhaustive. We have a lot of different organizations. So we started the discussion perhaps 2 years ago. This year we had we made a presentation, all this group, with the information management working group led by CartoNG and OCHA. So we are all GIS and other public health actors. Part of it is WHO and OCHA. So yes, they have a big part in the coordination and this experience in creation of areas. We don't have so many so far, but we would like just to have more Ministry of Health and people from the field, and just to get master list for health facilities. So regarding all the different methodology, after you will understand why we want all those health facilities list. We have different NGOs and communities, so it can be CartoNG and more H2H people, or more MSF and the medical side. We want to have some platform just to be able to centralize our data sets. So we involve HDX, the Humanitarian Data Exchange Platform, and so part of OCHA. And we also have Healthsites.io and Missing Maps as other platform or organization entities just to help us in this work. And we also have the presence of different academics like HeiGIT. We had also Warwick University, part of the first discussion. And we want to mix the different sectors and just to have this group of GIS experts, but also public health and medical experts, just to be able to work on health catchment areas. So just to start, I will just give the floor to Mark Herringer, but perhaps we can start with the first video from users.
I'm Denteh, nurse at King's Medical Center, as a referral coordinator of the hospital, with oversight responsibility to coordinate referrals within Mumbere District Health Directorate. I want to know the health zoning of all facilities within the district to facilitate transport, communication, and feedback of all referrals within the district. Thank you.
So I will give the floor to Mark now. Thank you.
Thanks, Rafa. Okay. Can everyone still see the slides, or do I need to present?
No, yeah, I think you need to present to start share your screen. Now it's working.
Okay. All right, guys. So, Rafa, thanks for the intro. And my name is Mark Herringer. I run the Healthsites.io platform. We're publishing baseline health facility data to OpenStreetMap. And it's been a pleasure to be part of this working group for the last year or so. And like we've just seen with Denteh, the nurse who described the utility of health catchment areas and the zones in this video, we would love this group to please use the GitHub link that I've placed into the Zoom chat space that you should all have access to. And we're using a specific format that you'll see on that wiki page. And essentially what we would like you to do is just to simply, if you're able to, write down a user story which refers to health catchment areas that means something to you. So as many of you I'm sure will know, when we get user stories from different personas, we're able to understand the different perspectives. And then from the Healthsites side, we're able to understand where the priority lies, and in our backlog we can prioritize those. So I would just like to invite you all to use that link. The GitHub is open, and we'd love to see your user story and be able to contact you at a later date and understand that user story further. So that's all from my side, short and sweet, but just during the course of this presentation, if you think of a user story, please share it with us. Over.
Thank you, Mark. I think so. Don't hesitate to fill in the chat with your user story. So I guess during the workshop we will talk a bit more about the health catchment areas and showing all the different methodologies. Perhaps everybody will get a better idea of what it is and just to know why it is useful for yourself. So I think the next presentation is from Marcel from HeiGIT, Heidelberg Institute of Geoinformation Technology in Germany. So Marcel.
Thank you, Raphaël. Hello from my side. I'm Marcel, and I'm a research assistant here at the University of Heidelberg at the Institute for Geoinformation Technology. Let me just share my screen. There we go. Okay. Can you all see my screen?
Yep.
Yes.
Okay, let me just... Okay, perfect. So yeah, my background is science. I don't have field experience like other people here in the panel. And yeah, it's about health catchment areas or health zones. So we approached that topic with travel time. So we did not look for like health planning zones by the government. So we focused more on, okay, where are the health facilities that provide care, and how far can we, how much time do you need to get to these facilities in which regions of country, for instance. And we look today, I want to look at two approaches here, two algorithms. One is isochrone based and one is a cost raster approach. So first, basic principle of care, I just put in together here. Of course, we have like people that seek care, that need care. And of course, there are barriers included, health insurance coverage, income, physical access, how far is it to a providing facility? And then we have the providing facilities, and sometimes they have limited capacities, special capacities. If I need, for instance, an operation theater, not every facility got an operation theater or an X-ray. So how can we model this access? And I said here, or I wrote here, despite scarcity of data, because in many regions of the world, of course, we don't have information about, okay, how is the health insurance coverage? What are the incomes? And especially for the facilities, we don't have information on the capacities. For instance, I mentioned it, where are operation theaters? Or if we take the COVID-19 pandemic, where are the ICU units, for instance? So in our analysis, in our case studies, we go for the distance as the simplest proxy for access barrier. And I mean, some of you probably are GIS people. We could do a classic buffer analysis using linear distance around our source points in this domain, health facilities. But we wanted to go for a more actual or the possible route. And yeah, for this we used a routing graph or a vector isochrone and cost raster. Okay, so the setup of the case studies. Our motivation was, first of all, there's a paper of Paul Yuma. He's with the KEMRI Wellcome Trust Research program in Kenya. They did a fairly nice analysis in sub-Saharan Africa on the access to hospitals. And they compared countries in terms of what proportion of the population can reach a hospital in 2 hours. This was in the domain of maternal health, as maybe some of you know that 2 hours are considered crucial if you have complications when you're pregnant. The second paper here was on the COVID numbers in Africa and what they might not cover, and general, the few attention on COVID in Africa. So that was our motivation to do an accessibility analysis in sub-Saharan Africa, especially for people, for older adults, older than 60 years, as we considered them most vulnerable to COVID. What data did we need for that? Of course, yeah, population distribution. Of course, we need hospitals as the providing care facilities. We used here OpenStreetMap. There is a tag for hospitals. This is amenity equals hospital. Then there is also from the team of Paul in Kenya, they provided a facility list that was assembled from master facility lists from different governments in sub-Saharan Africa, and they geo-enabled it using different methods, Google Earth, OpenStreetMap, etc. And then there is our access model. This, as I already told you, we used raster, cost raster approach. This was done with the access mod tool. This is a nice tool. You can find it on Google. It's developed by the University of Geneva together with the WHO. And then, yeah, the isochrone approach. This is based on a tool or a website, the Open Root Service, which is developed by our institute. Okay, what is isochrones? I talk a lot about it. I think the origin is probably Latin. Iso means equal, chron means time. And it basically is, we have a point, a center, a source point from which we want to know, okay, what area can I reach in a certain amount of time? I put it here, what places can I reach from possession X in time Y using Z? Yeah, as means of transport, of course. If I have a bike, I probably can only reach a fraction of the area I can reach if I would have a car. So basically, it's using a graph, a routing graph. These routing graphs are associated with weights in terms of, okay, how what's the speed limits here, or what speed can I drive given my means of transport? And therefore, it calculates up here in 60 minutes. In this direction, you can reach that far, in the opposite direction, that far, and then we spun a polygon or an area out of it, which we define also as a catchment area by physical access. Yeah, important for the ORS isochrone, you can use that, it's online. Currently, it's restricted to 1 hour, so probably not fit for every use case. It's fully open, you can host it yourself, then you're unrestricted, and you can also change the weights, for instance, of the model. And as I told you, yeah, it's totally open and based on the OpenStreetMap road network. These here are our results for the first case study where we used the Isochrone algorithm. We compared here the two data sets, OpenStreetMap versus Cambry. You see OpenStreetMap on the left side and Cambry on the right side. And then we show here the shared or the proportion of population reached by each country. The whole bar is the 60 minutes and each fraction here is a 10 minutes interval. So we see Burundi performs fairly well in both data sets. Especially in OpenStreetMap, we see that more than 50% of the population is reached within the first 10 minutes. And probably that might be a bit suspicious for some of you. And that's probably because of the underlying data, because there are many hospitals in OpenStreetMap. And probably most of them are not really hospitals. Most of them most likely are, or I assume they are more like health outposts, dispensaries, or health centers. I have two other examples here. Let's focus on Nigeria. This is on the bottom here. We see the population distribution, and then we see these black dots on that map in the center bottom. These are the hospitals. And we see there's like one huge cluster or three clusters just in the north of Nigeria, close to the city of Kano. And yeah, most likely, I did some research on that. That was an import actually. And I also assume that here, these are all health facilities, but not all of them are hospitals. These are most likely an overestimation. But still, just for the sake of these, of the data sets below, as we did not consider capacity, because we don't have, unfortunately, we don't have data about the capacities in both data sets. We see, although OpenStreetMap overestimates the hospitals, we have only a difference here of 10 to 20% of the reached population using Cambry or OpenStreetMap data. Okay, next method, cost raster. This is a more traditional approach to measuring access. So first of all, you need a friction surface raster layer. This is basically a raster in which every cell represents the cost to cross the cell. And in our model, cost means time. So if you have a look on the right side on this slide, each cell, let's say these are minutes, represent the minutes you need to cross this cell. And we have like one source point or one point toward from each cell we want to go towards. This is in the upper left. This is our hospital. And then we just go in every direction on the raster, and then we just accumulate the costs. And okay, how can we model these costs? For instance, natural obstacles are associated with high costs. Let's think about rivers, mountain ranges, or you could also say boundaries. If they are not that penetrable, they are associated with high costs. And roads, of course, but this depends on your mode of travel, are associated with reducing costs. And of course, a highway reduces the cost for a car much more than for a bike. So you can do that yourself with a raster calculator using land use information, road information, and rasterize it and put it all together. But I recommend there is one research team they call MAP. That's the Malaria's Atlas project. They are based in Perth, Australia, and they did two really cool publications. One is on access to cities, and just quite recently, also in the wake of COVID, they did a layer to access to healthcare, and they provide their data all freely online, and you can just download it and use it as a friction base, use your hospitals, and do your own analysis. So we did not use their friction layer. We did our analysis before they published it last month. So this was our second case study using a raster, cost raster approach, cost raster access algorithm. Why did we here use raster? Because we did not restrict ourselves to the 60 minutes, because the interesting areas in sub-Saharan Africa for the COVID response are probably those that are far away from hospitals or care in general. But we see Burundi in this example is also the top performant, but most likely, of course, we did use the same hospital layers here, and therefore this is not a surprise. Implementations, okay, maybe some of you are now motivated or know people in the organizations who want to do that by themselves. How can we use that? Or how can I conduct a similar analysis in my area of interest? Do you like desktop GIS? Then have a look at the ORS tools plugin. You can calculate isochrones with that plugin, fairly easy. If you want to do raster, then have a look for the Saga accumulated cost. But again, you need a friction layer first. In ArcGIS, unfortunately, there is no open root service toolbox available, but there's the service area tool. But this is also a bit sophisticated. You need your own routing graph in order to calculate that. For raster, you can use cost distance. If you like R, there's an ORS library available. This is basically a wrapper, including firing the requests against the API of the open root service. And for raster, you can use gdistance. This is also a library. Okay, this is my second last slide. Let me talk about the challenges. I already mentioned it. Quality of OpenStreetMap is questionable, and it varies in space. As we saw, Burundi is overestimated, probably regions like Somalia or Sudan may be underestimated, as there's not much focus of the community to map there. This is something to consider. And we also have a tool here at the Heidelberg Institute for Geoinformation Technology called Awesome. It's about the history analysis. So we could exclude, for example, we could exclude all or most of the facilities in Burundi, because I had a look at them and most of them were just edited one time, which is an indicator that these are of little quality. Of course, model uncertainties, these probably reflect rather best case, in my opinion. Open root service is a tool built for global coverage. So probably some timings you get, or time estimates you get in countries of the global south are maybe overestimated. So maybe add an error margin here. But let me talk about OpenStreetMap for health again, as I think OpenStreetMap, and I'm clearly speaking here also for Mark, OpenStreetMap is a promising data source for governments opening up the data. We have some examples. Rwanda opened it up. In India, super cool. They already had opened up their data, but several different pages from different agencies. I think it was about like one was blood banks, hospitals, health centers, and now there's RMSI, and they work also with local communities together to put that all together, publish it in OpenStreetMap, and have local communities to validate this information. And yeah, I'm an advocate for OpenStreetMap. I think this will also fuel transparency for these in the health domain. The last slide, isochrones or raster. Of course, quality, I already mentioned it. As the isochrones depend on the road network, you all have to consider that. If you work in a region where the OpenStreetMap road network is not reliable, you cannot use this tool. If you have a region where the road network is there, but the weights, the speed limits associated with the roads does not reflect your reality, you can build it yourself and just change the config file and associate, for instance, highway unknown is a typical tag for dirt roads, and 30 kilometers per hour might be too much in some regions, and you can just reduce it to 10, 15. Let me talk about scale in the end. It comes down to the question, what is your area? How big is it? What scale are we? Are we talking about country? Are we talking about provinces or global? Of course, if you are using rasters, the bigger your area, the coarser the resolution. Otherwise, your computational capacity will not be enough. For vector, we are a bit more flexible here, but keep in mind, if you restrict it to 60 hours, every scale is easy. if you're not restricted to 60 hours, better go for a regional or a country area of interest. Okay, so this was the input from my side. I hope some can take away some lessons here. If you're interested in more about that, just reach out to me via the chat, or I have 2 emails here. Yeah, so I think the next talk, I will give back to Raphaël first, I think, but the next talk is on master facility lists. Am I right?
Yes. Thank you, Marcel.
So
yes.
I talked a lot about quality, so I think we can just like move on with that conversation with the next talk.
Thank you, Marcel. I think so. Probably if you have any question, perhaps you can just put them on the chat directly for Marcel. If you have really specific question about Marcel's presentation, but we should just move on now with Jolynn Schmidt from Grade 3, who will present a bit more, yes, about master facility lists. So over to you.
Thank you. Hi, my name is Jolynn, and I am the data lead on the Grid 3 project. And so today I'm going to talk about geo-enabling a master health facility list and the lessons I've learned doing this. So part of the Grid 3 mission is to build spatial data solutions that make development goals achievable. And one of the main initiatives is identifying the locations of health facilities within a health catchment area. The master facility lists that government organizations such as the Ministry of Health create are different from country to country. And so sometimes it's just government facilities. Sometimes it's all facilities, including private ones that offer certain services. But often it's the case that they don't include geospatial data. So they're just a tabular list of the health facilities. And so what I do is try and geo-enable these lists. So to start that process, I, of course, have collected geospatial data. And this data can come from various organizations, either government data, other NGOs, or open source data. And so my first lesson is to get to know your data, since we're collecting it from many different places. Of course, there's the standard exploratory data analysis, but when you're collecting data from lots of different locations, there's other questions that are really important, such as when was the data collected, how was the data collected, and are there any known problems with the data? These will all help you make good decisions later on what's the best location for a health facility. So the second lesson is to normalize your data. When you're matching spatial data to a tabular master facility list, they need to share a vocabulary. So it's pretty standard to clean a data set. You're cleaning the names and creating maybe just a name field and a type field, but it's also important to look at administrative units. So in the example where your data set, say, is from 2016, and the master facility list is from 2020, it could be the case that health catchment areas were added or removed or renamed. And so making sure not only that your facility data is standard, but your administrative units are standard also. So trying to figure out, what's the new name of this health facility that's if the name changed. I'm sorry, administrative unit if the name changed. And then, of course, one of the more challenging aspects of normalizing your data is trying to come up with facility types that are standard across all of the data sets. So here's an example of 6 different data sources and the types in which each one of them used and the type that's used in the master facility list. It's often the case that they don't match one-to-one. And so really it's doing your best effort to come up with a shared vocabulary that you can use when matching a health facility to a geospatial health facility to a tabular master facility list. The third lesson is that you need to validate your spatial accuracy. So when you have data collected by independent sources, we can use them to confirm the location of a health facility. So errors exist within geospatial data for lots of different reasons. Two of the main reasons might be that the GPS is not synced. So in this example here, you see that the health facility was collected twice and is near each other, and that the third placement for this health facility is pretty far off the map. And it's also in water, so I doubt very much the person was actually standing there at the time that they collected the data. So this could be the case that the GPS wasn't synced, or maybe it was hand digitized from a paper map and is just not quite in the right location. There's lots of different problems we run into spatially, but one of the ones that seems to be fairly common is that within a given area, say 100 meters, there'll be a whole bunch of facilities clustered together. We're not exactly sure why this happens, but it seems to happen often. We think maybe it's either where they did the training, and so everybody, put in a point there, or possibly it's where the data was synced, and so it picked the geospatial location of where the data was uploaded versus where the data was collected. And then another common problem we run into is that the lat and long might be switched. And so sometimes you can actually just, catch this as the error and switch them back. But to pick the best location when you have all of these data points and you have these various errors, I start grading each point. So a single point from a health facility, for a health facility, I'm not sure if that's the right location. I feel better about the point if there's multiple points within a given distance, say of 100 meters. But it's best if I have two independent health facilities, both giving me the location within 100 meters of a health facility point. So in this case, I would look at these back to this initial scenario, and I would feel unsure about the point at the top, but feel pretty good about the 2 points down at the bottom. But what to do when none of the points agree with each other? So then I start looking more closely at what I call subclusters. So I have this 100 meters that I've looked and clustered all of these points together. But then I start looking at whether or not the names within that cluster agree with each other. And I've come up with this process of scoring. This is a Python script. I don't want to go too deep into it, but basically I start looking at the ratio of the number of points in a cluster versus the number of points in a subcluster. So for example, if there's 10 points and they all agree on a name, I'll have a high ratio. But in our example that I showed before, where I have a whole bunch of points and none of them agree on a name, it's going to have a really low ratio. Basically, at around 0.2, when the ratio gets that low, I no longer trust that point and I'll ignore it. The other ones I score as either feel good about or I'm unsure about. And so I'm answering questions with this by looking at, do all the points agree on a name? Do none of the points agree on a name? Or maybe do all but 1 point agrees on a name? So here is the example where I have one large cluster with a whole bunch of subclusters. Again, this would have a very low score and I would choose to ignore these points. But then let's get back to the scenario where I have two clusters and I still need to pick the best one. So what I do is I start looking for duplicate entries within 1 or 2 kilometers of each other. And going back to the score I gave them, I'm going to pick the cluster that I feel most confident about. So in this case, because I have 2 points in versus 1 point, I'm going to choose the cluster with the 2 points. And actually what I'll do is look inside that and I'll choose the point that is the most recently collected. Often it's the case that these points include information about the health facility. And so I want that attribute data. And so I'll choose the most recent point within that cluster. So after I feel really good about and cleaned my spatial data, I need to then actually do the match between the master health facility and the spatial data. And I utilize a Levenstein fuzzy matching, which because facility names will seldom match exactly. So here's examples of facilities that are all the same. They all are matches, but if you used an exact match, none of these would actually match. So we have to use what's called a fuzzy match. Fuzzy matches measures the distance between two strings. And I use two Python modules to do this. One of them is called fuzzy matcher, and it basically does a join between two fields using the fuzzy Levenstein algorithm to make that join. And then after I've joined the data, I then use fuzzy wuzzy, which just looks at the string and I evaluate how good of a match that was. So this is what that looks like. On the left, I have the first three fields here are from my master facility list. The next three fields are the fields that were chosen by Fuzzy Matcher as the best match from my spatial data set. And then these three fields are the scores for each combination as to how well those matches happen. So in this case, I have a score of 100 for the chiefdom. They're exactly the same. Facility and type, all 100%. You start getting into some, generally speaking, I use 92% as my cutoff. At 92%, I feel pretty confident they're the same. But even some of the lower numbers here, you can see like this one where one of them includes the chiefdom and one of them doesn't. It's only a score of 75, but they still match. When it starts getting into these lower scores, I actually visually inspect to confirm the accuracy. And so this is the output of that. This is my master facility list that I've geo-enabled. So the facility name provided by the master facility list, the facility name provided by the geospatial data, and the type that was associated with the master facility list. I now have my Latin long associated with it, and these are the sources that existed within the cluster that I chose. So in each of these cases, I had two separate sources that agreed on this location, which is to me the best match. So that's our process. Thank you very much. If you have any questions, you can definitely email here. They'll get in touch with me on info@grid3.org. Thanks.
Thank you, Jolynn, and you just respected the 10 minutes for everyone, so perfect.
I tried.
I think it's still really interesting, and I think I would have questions after, but perhaps we should also move to the next presentation first from Ravi Shankar from WHO. Are you okay, Ravi?
Absolutely, yes, thank you. I'm just trying to share my screen. Yeah. Can everybody see my screen, Claire?
Yes, perfect.
So I'm going to talk something tangential or create a way for us to discuss after this presentations. So I'm going to talk about health boundaries, top-down and bottom-up approach. So I put it in a way that will they talk to each other? There's a reason why I put that. So let me go back a little bit to the history of what WHO started 10 years ago to build these health boundaries. So it's a huge project, right? You have like almost 240 countries in the world to have the subnational geographies. At the second subnational means it's a quite big task. You have 50,000 plus geographies. You have so many million vertices. Each vertices has a meaning, right? You need to have alignment, international country boundary. All these challenges are there, and also we do store a historical versions of it. So even if Sudan is divided into New Sudan and South Sudan, we still hold the polygons for the whole Sudan, the historical geographies at subnational level. all of them have been stored from right from the year 2000. So there's a huge amount of historical boundaries as such. So what do we have with the health boundaries in our system? We have like at the first subnational level, we have for 220 countries, 3,000 plus geographies, and also end-dated geographies. So this is the coverage for the first level, and the second level, this is what we have. So we have for little lesser 207 countries, 42,000 plus geographies which is valid currently, and 5,000 plus which is end-dated. So this is updated once in 2 months, and we go through a process. So the process is actually the sharing, validation, harmonization, and code generation and dissemination. So sharing is a person from the WHO office talks with the Ministry of Health. He tries to get the boundary for that year. So sometimes it's even just a list of agreed names for that subnational geography, because the Ministry of Health might not have the shape files or so. So there's different scenarios, different things. So they get that, somehow it gets patched up and it gets validated with other boundaries possible. Then there's a harmonization to clean them and have them as per the international guidelines of boundaries with disputed areas and borders. So then a unique code is generated, and then this is given back to them. So this is what is one sphere of life. Then in the polio program also, we had a lot of needs to go one step lower than this. I'll tell you what I think people are just talking about. I think Mark and other mentioned about health catchment boundaries. So health boundaries are slightly different from health catchment boundaries. That's what I'm trying to talk here or have a discussion on. So health catchment areas are more like, I think initially Raphaël gave a definition for this. From our WHO or polio side, what we are thinking, it's more an operational boundary to demarcate the population served by a given health facility. That's how we are thinking. So it's more a bottom-up approach. It's a very consultative process. It is going in derived from a microplan. The right one is a microplan. Microplan is the one generally used in the field by polio program or measles or malaria or bed net distribution. It is used there to know a person goes and covers his area, his territory. So that is his operational area. All these areas put together is serving this health facility. So that becomes a health catchment area. So which area the health facility covers is that health catchment area. That can add up actually to come to a health boundary. But my question here is, one side we have health boundaries, which is actually got from the ministries, which might not be great or good, but it's more a top-to-down approach. On the right-hand side, you have a health catchment areas, which bottom-up approach, which is actually also supported by Ministry of Health, by various programs and partners, and it is coming from down. So let's put few differences between these two. This one is great for like a chloropleth map, or all programs are reporting based on health boundaries. You go to a country, there'll be 10 different programs which are collecting data, which will be actually trying to harmonize at first or second subnational level. They use the health boundaries. But the programs which are more into the field, into more operation and things like field data collection tools, they use health catchment areas as more reliable source. Health boundaries, the scales might be, sometimes might be even like 1 million scale, which will be like a rough, right? If a river goes, you can be half a kilometer of the river or like 5 kilometers of the river. If the river is the boundary between Kinshasa and Brazzaville, so there could be a big difference. So that is how the health catchment boundaries are there. And health catchment boundaries generally stop at the second subnational level. In some instances, we have gone to the third, fourth, fifth, but in general, we stop at the to have an harmonization across countries to compare. Then it is also for field data collection, health boundaries are used as just a start or when you don't have any other boundaries. The ideal thing is to use health catchment areas. The next point is how many we do have health catchment areas. to my knowledge, for the programs we worked in with partners, MSF, Grid 3 and other things, might be it covers like 10 to 15 countries in total globally. I know we did UC boundaries for Pakistan, Afghanistan clusters. We did something for Somalia. We did for Nigeria for sure. What boundaries and things are actually the health catchment areas. DRC, there's a lot of work happening by various partners. Mozambique, little bit tried, but we are not successful. The government didn't want to go to that lower level. So there are different, even within the country, it can be half completed. So that is the challenges we see with health catchment area. But health boundaries, sort of, it has everything, but accuracy is not there. So my question to everybody to trigger the discussion is, can we somehow add these together? Can we meet them at some point? Can we use the health catchment area to better the health boundaries? Can we use the health boundaries codes which are there, which are very harmonized, where all the programs collect the thing, to downstream to a start point to do the health catchment areas? I would stop there, Raphaël. I think I'm within my time, and over to you for the next presenter.
Thank you very much, Ravi. I think thank you for the precision, and probably yes, we will have a lot to discuss just after this last presentation. That I will share my screen for that.
Bonjour, je suis Mumbere Kombi Jackson, je suis cartographe et je suis contributeur OpenStreetMap. Et la cartographie que je mène, c'est dans le domaine sanitaire, la mise à jour des zones de santé, et la découpage de nouvelles zones de santé, la découpage des aires de santé, la découpage des villages et cellules sanitaires. La méthodologie utilisée dans cette activité, elle est généralement participative, avec implication du médecin chef de zone, infirmier titulaire, relais communautaire. Au niveau de la zone de santé, on récupère les données liées à la cartographie, entre autres les vrais noms des aires de santé, les vrais noms de chaque formation sanitaire. Après, on a fait appel aux infirmiers titulaires de chaque aire de santé. On fait appel aussi aux relais communautaires ainsi qu'aux leaders locaux. On fait une cartographie sur les sols. On essaie de délimiter la zone sur les sols et on fait le découpage sur les sols des aires de santé. Après le découpage sur le sol des aires de santé, chacun délimite sa partie. On fait un briefing. On les forme sur la collecte de données avec les outils comme OSM Ant et OSM Track. Comme je l'ai dit, OSM Ant, c'est pour la prise des points et OSM Track pour les limites de chaque aire de santé. Après, on fait la descente sur terrain. Après la formation, on fait la descente sur terrain. On délimite, donc on prélève les coordonnées, on collecte les données des routes, des limites. Si la limite, c'est une route, on prend les données ou le tracé de la route. Si c'est une rivière, on prend pour le tracé de la rivière. Après, on rentre, on compile les données et on projette les données sur le fond OpenStreetMap. On voit réellement si les lignes étaient vraiment sur la route ou c'était vraiment sur la rivière. Après, on crée la première donnée, donc le premier shapefile, et puis on imprime une carte à format A0, et puis on a fait encore appel, on délimite, on fait une validation participative. Chacun fait encore une validation de sa limite. Donc, la limite, cette validation s'est faite en deux aires de santé ou 3 des aires de santé voisines. Après, on valide, on fait encore la mise à jour de notre shapefile et on met en jour le shapefile. Après que le shapefile est mis en jour, elle est prête maintenant à être distribuée et à être utilisée. C'est en fait la méthodologie que nous utilisons sur la collecte de données et la mise à jour des zones de santé, aires de santé. Et pour cette mise à jour, il y a certaines difficultés que nous rencontrons sur terrain, entre autres les problèmes de la sécurité et les problèmes liés sur les infrastructures routières. C'est un peu la méthodologie que nous utilisons pour la collecte des données et la découpage de la mise à jour des zones de santé, aires de santé et cellules sanitaires. Et pour cela, je vous remercie de votre attention à cette petite explication et vidéo de la méthodologie utilisée pour la mise à jour et le découpage des aires de santé et cellules sanitaires. Je vous remercie.
Yes, so it was the first part, and we have a last video. So it's really talking more about the community and how it was done with the community in DRC from OSM DRC. So just for the last one before the discussion. Sorry, I think. Claire, Halleux?
Yes. Can you hear me?
Yes. So I just let you present.
Yeah, perfect. Thank you.
Should I click on?
So you can click play if it's not yet clicked. Yeah. So we have just heard from Jackson Mumbere Kombi, who was presenting from Beni in Eastern DRC. And the current presentation was prepared by Bienvenu Muluba, who is also an OpenStreetMap contributor. He's located in Butembo in Eastern DRC. I'm currently presenting for him because there was an issue with the subtitling. And so as not everyone understands French, I'm talking in English to summarize what he's saying in his presentation. So he's now describing the specific data model that was developed by the community in the Democratic Republic of the Congo to cover the different levels of information of the health sector and health administration. And so it includes the different health administration offices. In the DRC, we have identified 4 different levels of in the health administration. In this context, tags were identified also to cover health catchment areas, such as health zones, health areas, and health cells or health villages. And these are mapped in OpenStreetMap as relations. Relations are built on a set of different members, which can be segments of roads, rivers, administrative limits, and so on. And this relation model allows limits to stay synchronized with neighboring objects at all times. If a river is improved in its digitization in OpenStreetMap database, and that river was a part of the limit of a health zone, the health zone limit will be synchronized with the river and be automatically improved as well. There are also health facilities. So health facilities were divided in public and private ones, and each type of common health structure has been described on the OpenStreetMap wiki and defined in details, including examples and pictures, so that users can also understand what are the types of health facilities that are regularly met. In doing all this process, to more easily match the data faced on the ground with OSM tags, there were 3 different steps that were taken. There was a new tag specific to the country, which is called Health Facility CD, which was created to describe the actual classification of health facilities in the way it is currently used in the DRC. And it also includes, for instance, traditional healers, which can be quite common in the region. The community advocated for the addition and the rendering of a new value of the amenity tag. Amenity in the OpenStreetMap community is a very common tag, which is used for many different common objects in the Western world. And so on our side, we wanted facilities which do not have doctors to be rendered on the standard OpenStreetMap background, as many health centers, health posts, and dispensaries and places where community health workers are usually working are places which do very rarely have a doctor. And if it's a doctor, it's a visiting one, because doctors will usually stay in referral health centers or hospitals. And the last one was also that a tag was proposed and is now widely used in the DRC to map health boundaries, which means that there is now a 100% coverage of health zones limits in OpenStreetMap for the DRC. But this tag is not yet used anywhere outside the country. Health areas and health cells or villages are still under consideration and being mapped in a few places. As Marcel was mentioning earlier, the quality of OpenStreetMap data is variable and can be discutable. The OpenStreetMap community in the DRC, after contributing to a number of very localized objects, is now starting to work directly with the Ministry of Health divisions and partners for updating the master health facilities to identify the facilities which are still missing geolocation and finding the ones that are not part of the official master list. And as Ravi was mentioning earlier, the health areas that are used locally are really operational data. That means that they are quite dynamic, and the more local we go, the more variable they can be. So if there's a new dispensary that opens, if there are, elderly community health workers that die, I mean, health villages or health cells can be reshaped. It's also very much affected by population growth and displacements, as these types of areas are based on a certain amount of population. As a community health worker will generally follow, maybe monitor around like 50 households, and a health area will cover around like 10,000 people. And so all these limits and catchment areas will vary in time. And one of the questions we are having is what's the best data recipient for such variable data? We are currently using OpenStreetMap on our side as, being part of the OpenStreetMap community, but we are also very conscious that depending on the region and the amount of people that are currently contributing to the data updates, that might not always be the ideal solution. And so right now we are making extracts of this data and we are publishing them on our community HDX account to get them more easily accessed and searched by users. And so if you have any questions on this process of getting this health data in OSM, we'll be happy to discuss it as well. And Jackson and Muluba, who made the first two videos, are also part of this session and accessible to discuss. Thank you.
Thank you, Claire. So, and thank you to all the different presenters. So we are just on time, I think, like we planned. The idea is now just to have a discussion together. So we, I guess you probably have questions, but we also have questions. And the main objective was to see with all those different experiences everywhere. And yes, this one, I think DRC is a really good example because we have many different actors working there. So the idea is, how can we build standards? How can we have? How can we gather all those methodology together and perhaps just having knowledge of more of those methodology or people just working with health catchment areas? How can we gather everything, and how can we can we start to have standard processes just to be sure that we will have reliable data, or at least reliable metadata? I think it's also a bit the part. So I don't know if anyone from the group wants just to add anything else, or if we can start with questions. So perhaps I can continue a bit. I think we just stop me, and if anyone has anything else just to add, because regarding this topic, we said that, and we wanted just on purpose not to have too much and too long presentation, because we already have a lot of discussion. So it's been a few months already that we are working together with the different people around this table. On the health catchment areas, we have a lot of challenges. One of them is how can we, and perhaps it's really linked to this theme from the GONG this year, is people at the heart of information management. So how can we have more people around the table, and the one who are just working with all those data every day? So it means the different Ministry of Health, for example. How can we have them included in our discussion? So just for your information, Mark shared already in the beginning of the session the GitHub link. So we have a GitHub page where we start just to gather a lot of different information on health catchment areas. And so we meet with this group the first and third Thursday of each month at 2, I think it's 2 GMT, I think 2 p.m. for 1 hour. So feel free, if you are interested in being part of the conversation, just to join us. And yes, perhaps it can be interesting for you and for us also, just to have a bit more ideas and people around the table. I don't know, can I put someone on the spot? Ravi? Anything else to add from our group?
No, I can ask a question to on the raster model.
Yes, go.
Yeah, well, that was a great presentation. I really liked it, and even within our organization, actually all our senior managements are looking at that to see if my question is, has there been any field validation for any one of these use cases for us to take it forward? Really, we wanted to take this work because we are trying to use access mode. Access mode is very close to us, and we wanted to use for one snakebite project, and there's been request asked to see if we could use the raster cost model. Marcel, do you want to?
Sure.
Would like to partner with us, and if we choose some few countries where we wanted to try this out as a real case?
I'm super happy for that. Unfortunately, I'm based here in Heidelberg and have not much connections to the field. And this is you brought it up. This is a heavy problem for both of these models. And actually, if you see on the Access Mod page, there are so many publications, and also the team from MAP, that Malaria Atlas project. These models are super interesting, but of course, validation is needed. And I'm not too sure about publications that have validation. I would assume there are some, because there are many people using Access Mod also on smaller scales. And of course, you cannot, or it's hard to validate if you're on continental or world scale. But if you're in a province or even in a smaller scale, I think it would be much more feasible. And it's hardly needed, yeah. So I'm definitely up for that, but of course I think you are in a better position for that in-field validation, and I think that also comes down to the facilities in the end. Of course it's the distances. I talked about travel modes. cars and bikes, of course, that's maybe easy to model, because you say, okay, with a bike, you have like in an hour, maybe 10 to 15 kilometers. But come on, in those countries we are talking about, the mode of travel is a matatu or a taxi bus. And we all know that they leave when they are full, and this can take minutes to hours. To really model that would be super important. Yeah.
There is another question from Claire for you, Marcel, which is, are your sources using walking speed in forest environments?
For the isochrone approach, we rely on the weights or the type of path we have, or type of road we have in OpenStreetMap. So for instance, a path is associated with a certain speed. So if there is a forest, we can only model the travel through it if there's a path. For raster, it's different. You associate, for instance, a land use model. You say, okay, in urban environment, you can faster travel through these environments than through forests. So you associate it with less walking speed.
Thank you, Marcel. So in the chat, we have another question more for everybody, I think, from the group, from Pete Masters. Do you want to just to ask your question, to take the mic and ask your question, Pete, just to make it a bit more live?
Yeah, can you hear me?
Yes.
Excellent. Hi, Rafa. I was just wondering, like, lots of the presentation is really interesting, and lots of them mention to a greater or lesser extent the human capacity needed to either collect and or validate data. I wondered what the kind of, whether that was a rate limiting step or a barrier in doing this work, and to what extent, and how that might be mitigated or broken down as a barrier. Let me know if that didn't make any sense.
Yes, it is. I think, Mark, as you started to reply,
yeah, Pete, thanks for the question. I would say the specification of the license, so that stakeholders can compare and contrast their health catchment area data sets that they're using. You know, once we're all on the same playing field, then the human element can be deployed to clean the data and follow the lead that Jolynn and others are showing. But to begin with, I think one needs to specify the license and then put it somewhere where everyone can look at it and say, okay, this is the data, this is the license, let's start using it. And that's why we're promoting HDX as a tool to do that job. Over.
I would add also, and perhaps because Jolynn just showed really a specific technical part of the work they are doing in DRC with Grid Free also. But there is a big part which is linked to the community health workers, and so I think there is a need just to have also a bit more resources in the ground. And I would see that, at least from our side in MSF, as a challenge, because you need the resources just to do the things. And in few areas where you don't have any access, and I'm thinking about South Kivu, for example, where you have conflict and it's not really easy just to get in all the part of the countries. So we still challenge a bit just to get all the information that we need. I would put that as a challenge also. I don't know if anyone else.
Yeah, maybe Raphaël, I would like to add also to what Mark said also about the licensing. I think that's also very important. We have been working with our legal to make these health boundaries accessible to HDX. You know, one of the challenges we faced is there is a little bit confusion between the admin boundaries and health boundaries. So as a union agency, everybody is scared that somebody might take it in to a court, or it could be, right, this is how UN is representing this. If there is a dispute within a country, there are some states even within the country that are disputes. So we're trying to make this away from an administrative boundary and clearly calling that, hey, this is a health boundary, this is an operational boundary, this is nothing to do to demarcate any sort of political areas. So that is the first thing we are trying to do, so that this can be available through HTX. HTX is one perfect way for us to put it there. The next one is the whole process. I think first is the right model to actually collect this information and things. I think we need to a little bit streamline and make it accessible, then make that model very popular. I can see the same journey with OpenStreetMap did, right? The first thing when we were working in HeiGIT, it came with a small thing, but it really, the success of OpenStreetMap is also there was a clear model for people to contribute. Then there is a popularity, it became getting more popular. Then there was patronage from various entities. Then there was acceptance by the governments and big organization. I think that made a big difference. And then repeated commitment by the community and the user base. I think these sort of models is not there much into the health catchment thing. We are doing these boundaries, these micro plans, these things we are collecting. So still a clear model is not evolved out. Then a good patronage or supporting up has not come out yet. As one of the speakers said that in DRC we are able to do in some areas, but how do we replicate in other areas? So that areas has to be strengthened is what I feel. This is how I see it. Over to you, Raphaël.
Thank you, Ravi. There's Christian adding also that regarding resources from his part, he would like to propose using the Red Cross volunteers network, and definitely I think, but I think there are many questions because we have the humanitarian OpenStreetMap team, we have the community health worker, we have the different communities, I think, in the ground who can definitely help. I think what is not so easy is just how to organize this work and just to get this work done. And in the challenges, we were talking about licensing, but there is also the fact that it's still really dynamic. So we need to have maintenance of all the data that we create. So how to organize all that all together, I think, which are other questions. Anyone else?
Looks like this is a very shy group. Maybe I'll ask one more question. I don't know why there's not much participation.
Sorry, I'm not so shy.
Please, Pete, go ahead. I'm just filling in.
I'd like to follow up on something that Ravi said. So I think it's interesting the comparison between early kind of humanitarian OpenStreetMap use cases. But I like so I'm a big fan of the health boundary project, and worked a bit on it and talked to Raphaël on it a lot. But I don't think the story is all that strong. Like, I think OpenStreetMap for humanitarian purposes was a really motivating story, and so the community commitment that Ravi talked about wasn't too hard to convert because you could see the impact of the mapping, especially after disasters or during epidemics. Mapping health boundaries, I wonder whether the story is strong enough. Like, will people be motivated to map and maintain health boundaries based on the way we currently talk about it?
I think it's a good thing. Sorry.
Go ahead, Raphaël. Go ahead.
Yes, I think because we talked a lot about the user stories, and still today, you see, we try just to collect a bit more user stories. It's not easy. It's not easy just to have people involved. I think perhaps it's not so easy just to understand what is the main challenge and what is the problem with those health catchment areas. But I think we and even working with epidemiologists around me and just talking about what is our need, and clearly just to get all our dashboards done, just to get all the population data coming with one polygon, and just to have the right one. It's not so easy just for us within the system, just to try to convince people of the real need that we have of those health boundaries. So I think perhaps it's something we need to find another way perhaps to clarify this communication on what is the main issue around health catchment areas. But I remember that Mark asked from the beginning user story, and yes, it's not so easy just to have different user stories. So.
Rafa, I would just also add that the link that I've shared to the GitHub, in addition to us looking forward to connecting with this group through GitHub, which, as everyone knows, is such a powerful open source sharing tool, we have a logical framework document linked in there that Cephas and the group have established, where we define specific activities with the Ministry of Health and stakeholders in the health cluster, which we feel are leading towards data collaboration and eventually unity with regards to health catchment areas. And we invite the group to look at that and add comments to that logical framework, which as everybody probably knows, one needs to read from the bottom of the page and not down from the top. So that's just an invitation to the group and everyone listening in on the call to please use the wiki and look for that link, and please contact me if you can't find it. Over.
Thank you, Mark. And because we have questions also, and so we have participants from DRC, French-speaking people. So I think we were waiting for more participation from the people from the field, and I think we have few people. So perhaps they have things to say in French. Est-ce que vous voulez poser des questions en français? Si vous êtes intéressé, on peut faire la traduction. We can translate if you are interested in. For the 5 minutes.
Je veux peut-être faire le lien parce que Pete posait la question de est-ce qu'il y a peut-être une motivation suffisante qui vient au niveau de la communauté pour faire des remontées d'informations au niveau des limites des zones et aires de santé. Est-ce que c'est une donnée finalement qui intéresse suffisamment les gens? Et je pense que ce qu'on a pu voir au Nord Kivu et en Ituri, c'est que ce sont des données que la communauté utilise à tout moment, qu'elle met à jour à tout moment. C'est juste que le lien de cette mise à jour n'est pas répercuté vers les autres niveaux, quoi. Donc, je ne sais pas si vous voulez en dire quelques mots. So,
yes, please.
In case they cannot unmute themselves right now, one thing I wanted to mention is that in the current project that we are working on in Eastern DRC, the community health workers and the staff in the health centers are actually updating their microplans and working on health boundaries several times a year. So every year they are updating these, and which means that there is information, and this information is evolving, but the updates are not communicated upwards because they are really operational data used locally. And this communication issue is not only from bottom up, but even from up to the bottom as well, because there are a number of projects that are actually working on defining health boundaries, mapping them, and so on. They are involving the communities in collecting them either through the microplans or doing field work, field data collection. But in the end, you won't find this digitized map in the community's hands. So at the health center, people will continue doing like health hand-drawn maps because they never got the final product. And even if they had it, they don't have the tools to update it. So, I mean, we are currently working a bit on these questions, and we are hoping that at least with some else community, I mean, with some else facilities, we'll set up something which allow them to send, I mean, to have more dynamic communication in terms of spatial data. I don't know if anyone has any experience in this matter.
Absolutely, yes. Maybe I should answer because we were very close to that project in North Kivu and things. They might know Frederick Moyen, they might not know me. Actually, WHO supported and he was hired and sent to the field to support OSM. So that's how that project actually started a year and a half ago. And we definitely agree on that because these microplans are mainly supporting our polio and also Ebola response a bit. So these are the two, we are the two beneficiaries of that. We are using these boundaries very much, but the challenge we have is we're not able to take this little more upstream because it's not very standardized. It's not representative or completeness for the whole polio campaigns because polio campaigns is happening at like a bigger scale, but these are happening in small pieces. So there are some frustrations which we are going through. We really want to use this. We wanted to bring it up. We do not know how to, that's why I put the question, how do you make the top to down and bottom talk at some place? I think there needs to be some sort of mechanism more pushed in between to have these both talk together. And the perfect example is now for the COVID response. We are having an opportunity in the whole community to make big visibility on this, but we're missing the bus. As Pete said, we're not selling our story well. Actually, the story, there is a good story. We are not selling the story because the story is too complex on our side. The story is not made simple to the public, and we're not done our best effort to do that. Everybody is doing their own efforts, but we're not jointly done to tell the story out to the world. That's where I would stop, Claire. Thank you.
And if I can just again invite you to come to join our discussions that we have, and we can continue the discussion there. So Mark shared before the GitHub page that we have. So we should join next Thursday in the link in the GitHub. So please feel free just to welcome us if you are interested. And afterwards, we meet just twice a month, sorry. So don't hesitate to join us there and we can continue the discussion. And I will thanks again the GONG and every speakers and you also, obviously. Thanks a lot, everybody.